That's very helpful. You've touched on the notion of kind of moving things upstream about trying to get things in early. In terms of the kind of the time course of symptom development and thinking about that kind of issue, how early is early? Helen, I wonder if you have any views on that.
Well, this is of course one of the difficulties that, how do you determine what's normal adolescent behaviour and what is the very early signs of first episode psychosis. I mean, what the basic percentages tell us is that something like 80% of young people who develop first episode psychosis develop it between the ages of 16 and 30. Well, that's a big age range. The other thing to remember is that 5% of people who develop first episode psychosis develop it before the age of 15. And that's really important to remember. But I come back to this sort of, socks and bear cages. I have a 17-year-old son who, he would very happily stack his plates up and very happily not do his washing unless I went in and did it for him. That's normal teenage behaviour, but at what point does it merge into? And that's why I think we have a very big role in primary care in terms of the longitudinal relationship that we have with the young people in our practices. We saw them when they were 5 and when they were 10 and when they were 12 and 15, and we'll be able to spot small changes. And that helps give us a clue that something is going on there. And the other things we need to do, of course, is to listen to family concerns, to listen to mum when she comes in and she says, my kid actually, he hasn't been out in weeks, and normally he's a sociable lad or a sociable young woman, and I'm using the male gender here because it's slightly more common in boys than it is in girls. But to listen to mum about that, and particularly social withdrawal and mood changes. And again, we're back to, well, what's teenage and what's not. But we are in a unique position in primary care to be able to spot those subtle early signs.
Absolutely.
I suppose the other thing I'm conscious of is where the evidence base currently sits. So in terms of why should we as GPs be keen to get a youngster to engage a specialist mental health service? Well, there's a whole developing sort of core evidence base now which shows why it's important. For instance, we know that if you take a long time to access services with an active psychosis, then you can expect more hospital admission, more readmission. So long durations of untreated psychosis are bad for you. They affect your social outcomes, they affect your suicidality. The way the evidence base is now shifting is showing that even the earlier detection, even before people reach the threshold of psychosis, when they're distressed, they're chaotic, they're seeking help, but are yet to cross that threshold of psychotic symptomatology, that access to interventions like CBT may be able to avert the transition to psychosis. So that's a huge prize, and that really is an evidence demonstration of the value of intervening very early, much earlier than we've been traditionally thinking about. Now, my point as a GP is, how are you going to do it without primary care being on board with this? So there's a real task about how we engage GPs and others in primary care to be aware of those very early signs and symptoms, but to distinguish it from the normal noise of adolescence.
I wonder if I could just capture that really important thing there, and just direct this to you, Anthea, if that's okay, and to think, well, what is it as a GP that would kind of make you think, oh crikey, this isn't normal noise as an adolescent. No. This is moving more towards psychosis.
I do feel listening to family and friends is of key importance, and addressing their concerns. Certainly, of all the cases that I've diagnosed, it's always been because of family or friends coming to speak to me.
Right, so they've been the alert factor. They've come to you. They've been the person presenting to the surgery and saying, "Crikey, I wonder if you could kind of help with this young man or young lady." And then following on from that, then it's about kind of the nursing and what's happening from there. David,
that certainly picks up some of the points we looked at in audits in West Midlands in the sort of late 1990s and into 2000. The sort of the presentations. 80% of the time it was the mums, it was the family members coming up, particularly mums coming forward with concerns about a youngster, locked in their room, not communicating, talking themselves. And 20% of the time these youngsters had the courage to come and see someone like a GP. It takes a huge amount of courage. And then I think you're touching on the stigma issue. You know, having a confirmation that you may have a psychosis, schizophrenia, whatever these words that we use, you know, so easily drop. These are terrifying terms for a youngster, and it's the exact reason they won't come and see us. So I think another skill that we need as GPs is to be able to recognise where the youngster's problems lie. You know, if their problems are about getting a job or relationships or education, that's their problem. If we convert that into an expression called psychosis or schizophrenia, not only will we lose them because it doesn't make sense to them, we'll frighten them off. So I think it's about dealing with people where their problems are. And if we need to seek extra help, specialist help, we need to be doing it around where that young person sees their problem.
And I think that also highlights the importance of this notion of keeping a really active watching brief on a young person, because what we're saying really is it's subtle. There aren't any red flags like we have in so many other conditions in primary care. And it's important to flag that person up in your head, on the notes, maybe to the receptionist, certainly to mum and that individual themselves. Say, look, come back and see me in a couple of weeks. Don't leave it too open, like if you want to, I'm here type stuff, which we're all very good at. It's actually about making it a little bit more concrete, actively managing the follow-up of that young person until either it becomes something a little bit more concrete where you do want to refer on, or actually it was normal teenage behaviour, or it was something else. But this notion of actively watching and following up, I think, is critical because of the nebulous nature of the early presentations.
I think that's a fascinating point. I mean, I guess what we do know is that GPs are great at spotting barn door kind of psychosis, and we know that's something, but it's those more uncertain cases which I frequently hear that people struggle with, and I think that's something that you can't really learn from textbooks, isn't it? That's right. David, you
again, I mean, that's reinforced again looking back to those audits. About 7% of the youngsters presenting to us would have clear symptoms of psychosis. 7%. 50% that show mood disorder. It's often depression. A third will be panic disorder. A lot don't sleep. About a third will somatise. I mean, that's no different to any other mental health problem. But coming in with frank psychotic symptoms is the rarity, and it's that level. It's how you increase. It's how you lower your threshold for taking those sorts of symptoms seriously. In the context, perhaps, of someone who is beginning to show sort of behaviours that are odd, that are making their families anxious, that make you feel anxious when you see them, but may not be something you can sort of articulate clearly. But the presentations will be like any other mental health problem.
Is that the red flag? That uncertainty, that general mix of not quite understanding what's going on.
Unease.
Yes, but perhaps all together it's a red flag.
Put together, yes.
Yes. One of the things that we were talking about earlier was whether or not we should use as a sort of internal question this notion of, would you be surprised as a GP if this person turned out to have a diagnosis of psychosis in 6 months' time? Which is a difficult one to sort of put in a textbook or to put on a symptom checklist. But I think it fits very well with the uncertainty and the complexity of primary care, and just having that in the back of your head. Well, would I be surprised? And if you wouldn't be surprised, well then keep an active watching brief.
Perfect.